So good afternoon everyone. So my topic is clinical outcome of bilateral monofocal plus IOL ICBU with intended emetropia, group 1 non-monovision group with monofocal plus IOL with intended micromonovision in non-dominant eye, that is group 2 monovision. No financial disclosure. Monofocal plus IOLs can give good distance but not very good range of intermediate and near vision. With the arising need for better intermediate vision with least dysphotopsia, there is always a need felt for non-refractive extended depth of focus IOL without photic phenomenon. Additionally, ICBU has a modified aspheric anterior surface of the optic. It creates a continuous power profile, aims at improving vision for intermediate tasks compared with the standard monofocal and extends the depth of focus. It is based on diffractive technology without diffractive rims and without jaws. The purpose of this study is to compare clinical outcome of bilateral monofocal plus IOL ICBU with intended emetropia, that is group 1 non-monovision group, with monofocal plus IOL with intended micromonovision in non-dominant eye, group 2 monovision group. The outcome measures were uncorrected and corrected distance, intermediate and near visual acuity, contrast sensitivity, binocular defocus curve, spectacle independence, and photic phenomenon. This is a prospective non-randomized comparative study, single surgeon, tertiary eye care hospital. The group 1 is non-monovision group. Group 2 is monovision group. Both the group have 40 eyes, 20 patients. The first group has bilateral monofocal plus IOL with intended emetropia, ICBU. And second group has bilateral monofocal plus IOL with intended micromonovision group, micromonovision in non-dominant eye, ICBU only. So inclusion criteria is age 50 to 75, corneal astigmatism less than 0.75, endothelial cell count more than 2000, IOL implanted 20 to 23.5 range. In the back, the exclusion criteria are previous ocular trauma, irregular astigmatism, corneal dystrophy, history of glaucoma, intraocular inflammation, macular disease, or retinopathy, neuroophthalmic disease, intra and postoperative complications. The binocular uncorrected distance visual acuity and corrected distance visual acuity are better in group 1, that is the non-monovision, but comparable with group 2, that is the monovision group. The intermediate visual acuity, both uncorrected and distance corrected at 66 cm, is significantly better in group monovision, group 2. The uncorrected and corrected near visual acuity at 40 cm shows significantly better vision in monovision group, that is the group 2. The contrast sensitivity is comparable in both the groups. It is measured by modular transfer function measured on the eye trace. The binocular defocus curve was significantly better in monovision group at 1.5 to 2 and 2.5 versions. This is the graph. The post-operative reading speed at 66 cm and at up close were significantly more in group 2. The patients not at all bothered by starburst, halos and glares were comparable between group 1 and group 2 at 6 months. The proportion of patients having spectacle independence at intermediate distance 66 cm and near 40 cm were significantly more in monovision group 2 in bright light as well as in the dim light. What this study adds is that the bright light and dim light intermediate visual acuity at 66 cm is significantly better in monovision group 2, monofocal plus IOL with intended micromonovision in non-dominant eye, thus facilitating intermediate tasks significantly like computer work, reading labels in the shop, cards or board games, crafts, playing music. Near activity is significantly better in monovision group 2 in bright and dim light. The photic phenomenon, nighttime activities and night driving were comparable in both the groups. Thank you.
Dr. Kashyap, one point. What is the relevance of monovision nowadays with the availability of
because
continuous
this is a
range
cheaper
of
lens,
vision?
This is a cheaper lens.
Only the
cheaper lens, and if you see, there are a lot of modalities, like people are doing mix and match nowadays with trifocal in one, people have compared trifocal both eyes, then trifocal in one eye and multifocal in another eye. But then there is a problem of this photic phenomenon with them. This does not have a photic phenomenon, it's a very cheap lens. We have gone for a VVT, but VVT is very costly.